So treat things that impact movement so that things don't occur as fluidly, as fastly, as smoothly, and as automatically as they should, okay? And we're gonna focus on Parkinson's disease, but actually that's not the most common movement disorder. Essential tremor is the most common movement disorder that affects the general population. But Parkinson's disease is where we are together today. And it's sort of like a beginner's talk today. So a lot of you may already be very versed in Parkinson's on a personal level as a caregiver, or have read a lot. Sort of entertain the questions that fit here, but if somebody has a very particular question, we'll sort of take that later, given that there's so many folks, okay?
Dr. Solis-Cohen, can
Yeah.
you talk a little bit louder? It's a little hard in the back, I know.
Oh,
I'm
yes.
gonna shut this door, yes.
I've been talking all day, so by the end of the day, it's... So here's a little outline, and then maybe I'll sort of gear myself halfway across the room, of what we're going to be talking about. Parkinson's disease, what constitutes the diagnosis? What are the risk factors? How common is this? How does your doctor come up with the diagnosis? And who should make the diagnosis? What are those things that we call non-motor symptoms, and how do they differ from motor symptoms? We'll take a break, and then we'll talk about some of the treatment options, exercise, medications, and then we'll talk about that thing called motor fluctuations that you may have heard about, the ons, the offs that a person can experience, some advanced treatment options, and then some resources. Is that better? Volume-wise? Okay. All right, so what is Parkinson's disease? We think about it in a few different categories. It's not easy to just say one word, right? It's not just you shake or you move slowly. It's kind of a disease process that occurs on multiple levels. In the brain, on a cellular level, an anatomical level, like a structural level, a functional level, okay, and so forth. And we know that this is a neurologic disorder. We know that it's a neurodegenerative disorder, which means it progresses over the course of time. And we know that there is an abnormal accumulation of a protein, okay, that occurs. Now, this protein is called alpha-synuclein, and we all have it in our bodies. It's actually a normal protein to have. But what's not normal about it is how it can misfold, okay, and accumulate. See, the body is normally accustomed to making alpha-synuclein, and it's normally registering, okay, you've got enough alpha-synuclein, now I'm going to recycle it. And it gets tagged for this sort of automatic recycling process. And what happens if it is produced in a manner that you can't recycle it, it will accumulate. And then it will get in the way of normal brain cell functioning, and it will cause cell damage and cell death, okay? And so what was a normal protein now is a normal protein that has got in the way and caused cell death. And where that happens is within a certain population of brain cells that regulate dopamine. You guys may have heard of dopamine. It's a chemical we all make, a neurotransmitter. Okay, what that means is that this is a particular chemical that we use in the brain. It is used in other parts of the body, but I'm a little biased here because in the brain, it's responsible for normal fluid movements, okay? And if we can't produce the correct amounts of dopamine because this protein is getting in the way, we will have a problem of movement. And so abnormal alpha-synuclein folding can cause these accumulations of proteins that you may have heard of as Lewy body. Lewy body is found in Parkinson's disease and in another condition called Lewy body dementia. They have similarities and differences. Okay. Parkinson's disease is also diagnosed based on what you see as a movement disorder. And that's why this doesn't require an autopsy to diagnose. We don't need to go in there and measure the levels of dopamine in your brain, because that's not easy to do, right? But we can actually pick up on signs of a person's movement. So we can see that there's slowness of movement, perhaps on one side of the body more than another, stiffness, tremor, and that these motor symptoms are not, how should I say, they're very unique. Not everybody has the same constitution of motor symptoms. So what may constitute Parkinson's for one person may be different for somebody else. So the crux of the problem in Parkinson's is this dopamine deficit, like we talked about, that chemical in the brain. And if you took a look at a brain of a person who had Parkinson's or has Parkinson's, you would see that there is an actual visible difference, okay, in this area of the brain called the substantia nigra. And so what we have here is, this is showing you that this image is here. And if a person's sort of laying back because their nose is up and their eyeballs are here, and this is the back of their head, and this is their brain, and this is their brain, and this is their brain stem, and in particular an area called the midbrain, and in particular an area called the black stuff, substantia nigra, because when anatomists look at it, it just looks black. So that's where they got that name. And that's an area of dopamine transmission, okay? And in Parkinson's, what you see is it doesn't look as dark, right? There's an attenuation of that. And so I'm starting to sound like a broken record, but I think we're hitting it home that dopamine is affected. And in folks with Parkinson's, there's less dopamine for one cell to talk to another cell to regulate fast fluid movements. And here's a picture of the Lewy body in a brain cell. So in a dopamine neuron, the Lewy body there is an accumulation of that alpha-synuclein that's basically making the cell unhealthy and can't do its job of making dopamine. Questions?
What does alpha-synuclein usually do?
So it's part of regular cell-to-cell communication. So it's part of like the manufacturing system for cells, but it's found in other body parts, not just in the brain. Here, it's on a more of a maintenance kind of a protein, but we don't really know why we have alpha-synuclein in brain versus other body tissues. So the other part of it is, if we know that this is misfolding, how do we attack the alpha-synuclein in the brain and get rid of that? Because we all have alpha-synuclein and it's in other body parts. So if we're trying to think of a way of controlling the misfolded alpha-synuclein, we don't want to mess up on normal healthy alpha-synuclein in other body parts. Does that make sense? Mm-hmm. Okay.
I don't know why it is.
Well, they're learning a lot more about it, and now some of our research is dedicated to antibodies against alpha-synuclein. The thought is, if you could lessen that, can you help modify disease course or even halt progression? Yes.
So I had a DAT scan
Yeah.
to confirm that.
Yeah, so a DAT scan looks at dopamine levels in the brain, but a DAT scan is abnormal in a person who has Parkinson's, in a person who has multiple system atrophy, PSP, Lewy body disease. It is not that you get an abnormal DAT scan and you say, and I have Parkinson's. It is, you get an abnormal DAT scan and I have a dopamine deficit, but it is still up to your physician to determine which of those dopamine deficit conditions that you have. So DAT scan, abnormal, Parkinson's, they're not synonymous, but it is helpful. And it does differentiate Parkinson's from something like essential tremor or other conditions that can be lookalikes. But it is not, what?
You can't deny that you have something wrong.
Exactly, you can't deny that you have something wrong.
But it's
And
not
also it
strictly
helps-
diagnostic.
It's no, it is not.
I'm sorry, what was the question? It's not strictly diagnostic.
Okay.
I mean, yeah, so in the movement disorder world, a DAT scan is not necessary for the diagnosis. And also a normal DAT scan does not exclude the diagnosis, which is another scary thing. So, you know, it's helpful and I often use it in certain instances, but, you know, I practiced before a DAT scan too when that wasn't available for us, and it hasn't changed things so much. Go ahead.
Just said it was inconclusive, it would be inconclusive. You know, but when deciding whether to do it or not, you said it would not necessarily give the answer. So people would push it.
Yeah, individual questions like that are sort of, that's hard.
Yeah.
Because I'd have to know the whole situation to give more information. Sometimes it's not helpful and sometimes it is. Okay, yep.
Today is, I had a desk and Will was going at the Mayo Clinic. But today, is that the only, this is the only way that you diagnose at the time or wherever was providing
Your clinical exam.
Right.
Yeah, so the diagnosis is still by a neurologist clinical exam.
so
Correct.
there's no, I mean,
There's
it's
no,
all based on the symptoms.
correct. The most recent thing in the Parkinson's Foundation is now that there's a biomarker in spinal fluid that they're starting to develop, but there's no like blood test or quick and easy sort of,
Right.
do I have it, do I not?
And that just tells you that potentially down the road you could get it, but you may not get it right. The biomarker that people have, is that?
I think that's like Parkinson's disease, like 301 discussion. So this is the second most common neurodegenerative disorder. 1 million individuals in the US are living with Parkinson's. 90,000 in the US are diagnosed each year. And that's up from years before. As we see the population age together, that number is going to go up. More than 10 million people living with Parkinson's worldwide. I think we're asking a lot of good questions, so I'm going to start to keep track of time. Okay, so the primary risk factor is age, and the incidence of Parkinson's increases after the age of 65, more often seen in men than in women at all ages. And oh yeah, here's the stat, 1.5 times higher than previously reported new Parkinson's cases per year. I think the prior was about 65 or 70,000 the last time they did epidemiologic study. So Parkinson's, what is it caused by? The fact that I have like a slide with many bullet points means it's not one thing, right? So we usually say that there are contributions from these categories, and in one individual, it may be like all genetic for them. In another individual, it may be a pretty heavy proportion of their environmental exposure. And for another individual, we may not find any clear thing that you can hang your hat on to say, oh, this is why you got Parkinson's. But I will tell you, as a person who sees Parkinson's all the time, the more common story is, I don't really have any of that. Nobody in my family has it. It's just me. Why did I get it? Are you sure I have it? Because we don't know about this in my family. That's more common. And a smaller subset will say, Uncle Joe had Parkinson's, you know, Aunt Yolanda had Parkinson's, grandpa, you know, whatever had Parkinson's. And then we may find they have this genetic predisposition. A plug for PD genes. So if you go to the Parkinson Foundation, they offer a free genetic test called PD gene generation. And if they're still enrolling now, I don't know if they've finished enrollment for this year. If not, you'll circle back next calendar year. They offer a small panel of genes that a person who has Parkinson's is eligible to have that analysis, that genetic analysis. Now, a lot of my patients come back and say, all right, so my gene panel was negative. You're wrong. And I'll say, no. Just because you don't have one of those genes come back as abnormal doesn't mean you have Parkinson's. Because like we learned from you, Parkinson's is not a diagnosis that we have a clear, easy test for. It's based on a clinical exam, okay? Questions here?
Would it be valuable for children to know this genetic?
So if you have a very strongly transmissible family history of Parkinson's, it is beneficial for any child who wants to know, older than the age of 18, to seek counsel from a genetic counselor. Genetic counseling strongly.
I was thinking more in terms of eliminating that, saying, no, without a genetic counselor, there isn't any genetic. It might be reassuring to children.
I would say it's falsely reassuring because we're only testing for a certain number of genes that are commercially available. And what if the gene that a person has is just not available for testing, but they still have that genetic predisposition, you know? So I think it's always really complicated.
Okay.
Anybody else? Yeah.
What's the name of that gene panel test?
PD gene, Gene, but I think they do PD gene generation, like they put PD in front of the word generation, and they sort of do like a pun on words, like a little, right? Isn't that it?
Yeah, the gene is capitalized, so it's PD generation, but the GE.
But the GENE is capitalized, yeah. Yeah, so if you type in PD and then write generation, all as one word, you'll find it. Yeah, thank you. Yes.
Suppose that you may have gotten it from an environmental toxin or whatever. Are there blood tests to show that you were exposed to Agent Orange, solvents, pesticides?
Generally speaking, not.
No way.
No.
Well, how would you know that those environmental factors are covering it?
Well, it's based on research studies of people who have had significant exposures. So, you know, the government has studied the effects of Agent Orange, and now this is a covered disability. So if you have Parkinson's or Parkinsonism and you've had Agent Orange exposure, you've already done it. So it's a clinical diagnosis. We ask a lot of questions, and usually I apologize to patients about how many questions I've had to ask to make sure that I'm not coming to a conclusion without understanding all about them, okay? But we're asking the nitty gritty things, like how many bowel movements a day are you having, okay? And, you know, things that are really personal to sort of find out a lot about how their nervous system is working. And then the cardinal feature. So if there was one feature that is the most important, it is this fancy word called bradykinesia, okay? Slowness of movement. Kinesis is movement. Brady denotes the slowness, okay? And then you need one of these other signs. So you will have bradykinesia as your hallmark feature, and then either rigidity, which is stiffness. Your doctor will sort of feel your arms or your legs. Shake, you used to be the fast walker and now your spouse is walking faster than you, okay? Speaking, there may be a pause before you speak, or just the rate of speaking is slower. The volume of speaking less. Swallowing may happen more slowly, and then what happens? If you don't swallow, where is it gonna go? Out your mouth, and you'll drool, okay? It's not that you're really producing more saliva, it's just not getting recycled as much as it normally would. Micrographia is our fancy word for writing that is very small font. And often when people come to see me, they don't say, I have bradykinesia. What do they say? They say, I'm weak. I'm weak. And neurologists say, no, you're not weak. You've got strength like an ox, right? They push on your arms, they push on your legs, you're strong. Then you feel like, I don't know what's wrong with me. But it's not weakness. It's these other things that are slowness, okay? Tremor in Parkinson's classically starts on one side of the body and then may or may not go to the other. It is most prominent when a person's at rest, but Parkinson's tremor can do what it wants. It is not always at rest. And it's bothersome for folks if it happens on their dominant hand, if it wakes them up from sleep, or if it makes sleeping hard because it's shaking there when they're trying to go to bed. Yes.
Is that part of restless leg syndrome?
Totally different. That's another non-motor symptom that goes along with this that I don't know if I'll get to. Restless legs, I will answer it now, is a movement disorder that usually coincides with prolonged periods of rest. So sitting, a plane ride, a car ride, or trying to relax before bed when you're watching TV. It's usually a feeling before either a voluntary or semi-voluntary movement. So like a feeling like I just can't get comfortable on my legs, and then I walk around and I make it get better, okay? But restless legs does not equate with a rhythmic voluntary movement like a tremor. Those are different.
It is associated with what?
Correct. Yes, and should be, right? But it is a non-motor symptom in Parkinson's, and it requires a neurologist who will dedicate part of a visit or a visit to treat. And sometimes when we're dealing with nighttime symptoms, we will get our sleep medicine doctors involved. So there's actual sleep doctors. And it's not all just like, oh, it's definitely REM sleep behavior disorder. There's a couple other things that it could be. And it depends on what your history is about how you treat it and what you do about it. But that, in my mind, is better served with dedicated attention and a treatment plan. Okay? Yes.
Could you help us, you define what is a non-motor? Because
Yeah, I know.
movement
We're
and
kind of out of order, so I'm going to keep going. So, excellent question. I will address it. You're good.
Sounds like motor.
So, all right, I've stuck in slides here. Should I skip it? No, we'll do it. All right, so this is a myth. I don't have a tremor, so I don't have Parkinson's disease. Not true. You guys learned the hallmark of Parkinson's is slowness. Tremor may or may not be present. Okay, I'm going to have to move faster. Rigidity or stiffness is usually impacting one side of the body, but can be both straight away. And usually a person doesn't really understand how to describe this to me. And I'll find it when I do my exam, okay? But here's some things I'll ask about. Do you have difficulty pulling the seat belt over, okay? How big length, so how far apart your feet are when they touch the ground is less. How high the feet pick up while you take a stride is lower. What will look like a straight posture is now knees bent, sort of hip bent and shoulders down is going to be the new posture. I've seen a lot of caregivers say, come on, straight, straight, stand straight. It's not that they want to do this, right? This is part of what's happening. You may see this thing called freezing. Who knows what freezing is? Anybody? Yeah? Yeah.
Feet stuck to the floor.
Feet stuck to the floor. Yeah. And it may be that you're sort of like stuck there, do this thing, and then we're going, right? That's very debilitating. Okay? Very disruptive. And sometimes people will tell me, well, I feel like there's somebody behind me who randomly pushes me. And all of a sudden, I feel like I've got a big rush forward, and I can't control that acceleration forward. So fall. the sort of like Parkinson's 201, yes, or the arm can be sort of like strung into the body or postured with the hand. Yes. People can have dystonia separate from Parkinson's too, just so you know. Dyskinesia is what we call like a dance-like movement, and other people call it different things. I have people who call it my head bobble or my shoulder wiggle or my leg sort of like jiggles around. I usually tell people, have you seen Michael J. Fox recently? Because one of the complications of his treatment plan is that he struggles with dyskinesias. And it can be a cause of injury for people, social embarrassment for people. But sometimes it bothers people's partners more than it does themselves. So not all dyskinesia needs to be treated, okay? It requires a conversation of what the treatment options are.
Parkinson's 302.
Yeah, 1,009, yeah, okay. An MRI brain is not necessary for the diagnosis, but you may see a neurologist order it if they're trying to rule out a mimic condition. They may also order it to rule out other things going on in the brain, okay? But you can't say, oh, my MRI was normal, I don't have Parkinson's, right? Now you guys know that. And then the DAT scan is that dopamine transporter scan that we talked about. It may or may not be a thing that we do.
What would show up?
Oh, we're looking for other things. So for example, hypothyroidism, low thyroid function, can cause a person to walk slowly and look like they have Parkinson's, okay? Some medications may also cause people to look like they have Parkinson's. So we may look for other things. Yes.
So a year ago, I had a DAT scan. I should ask my doctor
I
about.
think it's worth talking to your doctor on an individual level. Oh, here we go. My doctor ruled out Parkinson's disease with an MRI. Myth. DAT scan. We already talked about this. I'm going to skip it. Parkinsonism. Okay, you've noticed my word choice. I think of Parkinsonism as an umbrella. Okay, it is a term that describes slowness, plus or minus, rigidity, tremor, walking instability. Parkinsonism is just me saying all that without saying all that, okay? Under that umbrella, the most common is Parkinson's disease, okay, which is what we call the typical, okay? And then there's the atypicals, such as these other conditions there, corticobasal degeneration, progressive supranuclear palsy, multiple system atrophy, dementia with Lewy bodies, and some others, vascular Parkinsonism and medication-induced Parkinsonism. Usually, to talk about the atypicals, you need a whole other 2-hour lecture. So I'm just going to tell you that those have what we call red flag signs of early cognitive impairment, early bladder dysfunction, severe bladder dysfunction, early and severe blood pressure dysregulation, severe constipation. Confusing for you, then I'm doing my job. Okay. All right, I know, sorry. Non-motor symptoms, we've made it. So, you know, I could barely fit them on this slide, and I think I had to leave out some. Anosmia, loss of sense of smell, typically precedes motor symptoms by decades, okay? Decades before a person starts to move slow. Constipation can also precede motor symptoms by decades. Urinary frequency and urgency, also that's common as a person gets older. So then how do you distinguish it? It's tricky. REM sleep behavior disorder, active dreaming. A bear is chasing you. You're fighting in the middle of the night. You're waking up in a fight with the lampshade, right? Like things like that. Now, is REM sleep behavior disorder exclusive to Parkinson's? No, no. It can occur in other entities, and you can just have REM sleep behavior disorder and never have Parkinson's. So again, it's complicated. Restless leg syndrome. I sort of said that in the beginning, and there's many people who have restless leg syndrome who don't develop Parkinson's too, okay? Cognitive changes, not necessarily like you can't remember something, but more of, if you're trying to do 3 things now and the phone rings, where were you? Where were you in that process? That gets hard, okay? Hallucinations may or may not happen. Mood changes. And in clinic, I'm very annoying about this one because I feel like it's one that's not as well addressed. Anxiety, depression, apathy, which looks like a person may not care, they just don't have that drive, but they're not necessarily depressed. Or impulsivity, like not knowing how to sort of back off when they would otherwise, and they're sort of like getting up, moving around, antsy-pantsy kind of thing. All of that is much more common and may precede motor symptoms and needs to be addressed separate from Parkinson's medicines, typically with medication. Orthostatic hypotension, our fancy word for when you go from laying to sitting to standing. What typically is supposed to happen is the body accommodates for that transition of position. In this condition, what doesn't happen is it doesn't accommodate. Your blood pressure goes down and you may pass out. Or your blood pressure when you stand up may be something obscenely low, like 60 over 30. Doctors, how are you alive? So big problem. Fatigue, drooling, sexual dysfunction, erectile dysfunction in particular, skin changes, dryness, flaking, these little patches that grow on the skin. And then in Colorado, having so many skin changes because of where we are, melanoma too, in much higher rates. I mean, I shouldn't say it like that. Melanoma has a higher association in Parkinson's, but in Colorado, we all need to do a better job of getting our skin checked because of where we are, okay? Shortness of breath is an interesting association. Sweating, and then pain. Really interesting articles about pain and Parkinson's and how we don't understand why pain has a greater ratings anywhere. Oh yeah, so the 3 most common non-motor symptoms before motor symptoms develop: anosmia, constipation, and REM sleep behavior disorder. Those are the 3 that are most likely to be there before you start developing the motor. And a lot of people think that restless legs is one of them, but it's not. So when people come to me and I always ask about those 3, if anybody has a tremor, to sort of see what the risk is in our heads. Go ahead.
Yeah, I'm one of those people that 12, 13 years ago, I lost my sense of smell. And then the next year, I started having active dreaming, punching, kicking, screaming, the whole bit. If I would have known 15 years ago that those were precursors to Parkinson's, would that have been helpful?
Oh, it's a fabulous question. So the good thing, thank you.
I
Thank you.
have a thoughtful.
So, no, but I did forget, and I will forget, I'm not good at that. There's other things I'm good at. So the question is, she had an experience with loss of sense of smell and active dreaming. And
Like
15 years ago, could there have been something that she could have done differently, right? Medicine maybe that you could have tried early on to help prevent the progression,
Yes.
or prevent the onset.
Yeah.
Yeah, so that's what's being studied, and this is called prodromal PD. So what is going on in research now is, yeah,
And then they're like,
yeah, yes.
I know there's, I guess, like with cancer or whatever, there's stages, right? Stages.
Yeah, yeah.
Is there any definitive timeline as far as the stages go? You know, stage
Yeah, so
one,
we have
1 to 5 years?
5 stages.
Right.
And it's the Hohen and Yahr staging system, and it's mostly used for research purposes to categorize individuals as they like trial a medication or study this, that, or the other. I don't like it in the clinical world. Just seeing patients and helping people, you know, navigate this condition, because there's no defined like you must be in stage 1 for 5 years, and then oh, here comes stage 2. It doesn't always happen like that, and not everybody goes through all 5 stages. So I actually tell people don't look at the stages because you're going to mislead yourself. Yes.
Has there been an association of cancer treatment with Parkinson's?
Cancer treatment with Parkinson's. Yes, they've used one cancer drug in Parkinson's, but it didn't reach.
I mean, if you've been treated for cancer and then get Parkinson's.
Is there a risk of chemotherapy to Parkinson's? No, not that I'm aware of. But I thought you were asking, they actually trialed a leukemia drug to see if it was going to be beneficial in Parkinson's, and it was not. So. All right, so here's the take home on this one. 98% of people have a non-motor symptom who have Parkinson's. I want to meet those 2% that don't. I'll find them. And then the average individual has 8 different non-motor symptoms. So make sure that you're thinking about these, because like, you know, the comment over here about sleep was, if you don't feel comfortable talking about non-motor symptoms with your doctor, you know, you should find a person who you can talk to those non-motor symptoms about. And it's not that always the neurologist is the right person, so I don't mean to say that, but we may need a sleep doctor, a urologist, a gastroenterologist, and so forth to really make sure that all the needs are met. As a Parkinson's doc, I feel like a PCP, and my staff jokes, yesterday they always made fun of me because, like, Dr. Solis-Cohen, you shouldn't be treating UTIs. And you shouldn't be referring people to like alcohol rehab counseling. And I'm like, well, don't you understand that Parkinson's is all encompassing and there's addiction problems? And yes, they get urinary tract infections. And so it winds up feeling like a PCP. So Brandy's going to love that when I tell her I said it today. All right, you get a break. Thanks for listening.
So let's try to get back in, what do you do about another 45?
Is what?
Exercise.
Oh, exercise. Carbidopa-levodopa is still a symptomatic management, but the closest thing that's going to change the trajectory is exercise. And it's regular exercise, and it's a lot of work, and it's at least 150 minutes a week of work. But if you think about the importance of exercise, you put it on pedestal 1, 2, and 3, way above your carbidopa-levodopa, because that's what's going to be helpful the most in the long run. Good? Okay.
Will it actually work, or is it just slow to progression?
Slow. But I will tell you an anecdote during the time of COVID, one second, but during the time of COVID, when all the gyms shut down and people sort of like had that March, April, May experience of like being bunkered down and stopped exercising, people would come to not just me, but a lot of movement docs and say, my symptoms were out of control. And the common theme was a couple, like one was mood was clearly decompensated for some folks, but also guess who wasn't exercising anymore because their gym closed or their pool closed, or you know, their Parkinson's boxing class closed. So we saw it, and it was obviously not a great situation to be in. But I say that to sort of further remind us how powerful this is of a treatment option. Yes, your question.
I was just wondering about like the types of exercises that are more beneficial. Does it have to be cardio or?
Yeah, so that's a good question. Are we having a talk on exercise in Parkinson's? I'm going, the third session will be dedicated to that, and that does deserve its own attention, okay? For now, until you can attend that one, and if you can, the running line is whatever you can do and you like doing will work out better than you not doing anything, because you're going to need to do this and to commit to this for the rest of your life, okay? And so it's better for you to walk the dog or do Pilates than to do a boxing class. And I think that's sort of unanimous in the field. A lot of people are arguing, you know, high intensity is going to be better than Tai Chi for this, that, or the other metric. And there's truth to those things, but those are more nuances. We just need y'all to exercise. Okay, yes. Minutes. Did I say hours? I've been going all day. Sometimes I do stuff like that. I'm sorry. Good catch. I said minutes or say hours? Man, I would have had a heart attack if I were you. How am I going to fit that in? Great question. All right, exercise. Oh yeah, see, 150 minutes per week. That would have answered it. There we go. And best exercise, something that you'll stick with. I should just keep advancing my slides. All right, rehab therapy. So this is another option that everybody who has Parkinson's is eligible for pretty much whenever you want, okay? So therapies, physical therapy, PT, occupational therapy, OT, speech therapy, swallowing therapy, cognitive therapy, okay? Always available. A whole lot of work that you have to invest. It's like having another job, exactly. And then the thing is that some people find they're more beneficial than others. And then the other thing that I find, especially for speech therapy, is it helps while you do it, and as soon as you finish your session, if you don't continue your exercises, the default is to talk softer, right? Or potentially to mumble, right? And so these are helpful to learn strategies, but I can't expect that a person is going to be in therapy all the time for the rest of their life. That is not possible. It's not an expectation. Yes.
And we have follow-up classes, so when you do the certification, we have weekly classes, so you do keep practicing.
Yes.
I figure when she has to repeat herself 3 or 4 times, that's just more exercise.
Yeah.
What?
Question is there an optimal time to start physical therapy? You know, no. If a person is falling and they're at a risk for themselves, they should be doing it. If a person is open to educating themselves on how to help themselves, that's a great opportunity. You have to personally be invested in this. I can't drag you there every day, right? So if you're not into it and you'd rather exercise and you're safe doing that, then maybe that's right for you. And, you know, so I think it's more about that on an individual level. You guys may hear LSVT, Lee Silverman Voice Therapy, Voice Treatment. And I love this website, LSVT Global. It's a great way to find Parkinson's certified therapists. So you can go to that website, and then off to the right, it says find an LSVT clinician, and then you can put in your zip code and find if you want to medications work. I mean, I feel like we've already talked about this. Okay. Carbidopa-levodopa is what I like to call like the most natural way of replacing dopamine that's actually prescription, okay? Carbidopa, levodopa is the gold standard treatment for more than 50 years, 50 years. And levodopa is the active ingredient. I think this is the only medication I actually talk about in some detail, so don't worry, I'm gonna follow my original thing of not talking about all of them, but this one. So levodopa is an amino acid, which means it's a protein breakdown product. Amino acids are going to be absorbed naturally in the small intestine. That's where when we eat a hamburger, for example, our small intestine will absorb the broken down product amino acid, and that will go throughout the body for digestion, right? But levodopa, what we do is we absorb it there, then it goes into our blood, crosses the blood-brain barrier, okay, which is this covering around the brain that protects it from toxic things, but some medications like levodopa have to get through. And your body converts that levodopa to dopamine by a natural enzyme that we all have, and then we get more dopamine. And you'll notice that levodopa is not given to you alone. It's given always combined with carbidopa, because levodopa alone causes a lot of unwanted side effects. It causes a person to vomit, they will have low blood pressure, they will feel flushed. It is not fun, okay? Carbidopa prevents those side effects because none of the levodopa goes to dopamine in the blood. It goes just to dopamine in the brain, okay? That avoids the side effects. And so you will not find just levodopa. The only formulation where there's levodopa alone is an inhaler called Inbrija. That's a whole separate story. Okay? Now, side effects can still occur even when you're taking carbidopa with levodopa. And side effects that you'll most commonly see are listed there. Nausea, vomiting, rarely. Lightheadedness, yeah. Low blood pressure, confusion, hallucinations, dyskinesias, the wiggly extra things, right? Fatigue, even, okay? And there's ways of dealing with these common side effects too. So if a person comes to me and they said, I'm sorry, but I can't tolerate that yellow pill for anything. All right, you know, we're gonna try some things, we're gonna try some other formulations. I may have to give you a nausea medicine with the carbidopa levo straight away. But there's ways of helping folks tolerate it.
A question on taking the carbidopa levodopa, you know, that's what I take. When I take medicine, I just maybe take 2 gulps of water and swallow the pill. But I heard that because it's absorbed in the small intestine, you should drink a whole cup of water when you take your pill. Is that true? Because I just do 2 gulps and I'm done.
Yeah, the water is not as important. This is an anecdote from me, so that I don't think there's a lot of good science behind how much you have to drink to get your levodopa absorbed. There's more science behind the fact, I used to have a slide on my other deck, but I was looking for it, about food interaction. So you're supposed to have carbidopa, levodopa 30 minutes before a meal, or at least an hour after, to avoid protein in your food from breaking down and then competing with where the levodopa gets absorbed in the small intestine. But the whole thing of like 2 sips of water versus a cup of water is not as important. Personally, I really push hydration with my patients because carbidopa, levodopa tends to lower blood pressure. Parkinson's folks tend to have lower blood pressure, really need that hydration. And I find this 3 times a day, you know, drug, which, you know, some people on 4 or 5 or 6 times a day. It's a great opportunity to work on your hydration. So, you know, so you're not hurting yourself by drinking more water. It's a good thing to be doing, but the science behind it and whether it's like evidence-based recommendation, I don't know.
Just don't eat your meal and then take your medicine. Because
That's the textbook answer.
I usually wait, if I eat, I wait 2 hours before I take my carbidopa.
That's very good.
And after I take it, if somebody wants me to eat something, my sister says, here, eat this. I'll say, I can't eat anything for an hour because I just ate my pill.
Mhm.
So,
Yeah,
so food is a bigger problem than water.
yes. Food is a bigger problem than the water. And also the food recommendation has to be addressed individually with your doctor, because the other problem with that is people stop eating, right? And you need to be nutritionally appropriate to deal with a neurologic condition too, right? So, what if you're dosing every 2 hours? When do you eat? Right? So we've got to find a balance. And so ask that question to your doctor. I heard a talk. Dr. Solis-Cohen wanted me to ask you what I'm supposed to do with meals, with meds, because I will tell you in my clinic, I give different answers to different people. Okay, that's my personal thing of, it depends on what their motor symptoms look like, how well treated they are, how much their motor symptoms can tolerate a reduction related to that hamburger that they had with their pill. So it's not all one fits all, okay? Question?
Just generally speaking, is there any criteria that doctors use to determine, like, say, if somebody's on a low level dosage of this medication, that they increase it?
Their exam.
Their exam.
Yeah. Yep.
Remember your heat flashes, is that something that's kind of normal with that or no?
Yeah. Sorry, I have to ask for forgiveness from our back audience. So what defines how to increase or decrease carbidopa, levodopa dosing? And it's the clinical exam that the doc sees in the office and how well treated their motor symptoms are. And then the question over here is what again? Oh, heat flashes, yeah. Heat flashes are a non-motor symptom in Parkinson's. It can be caused by other things though, so we always have to get the primary care doctor involved. Sometimes it's a sign that medicines are wearing off, actually, if a person has a wave of a heat flash.
I get them literally 5 minutes after taking my medication.
Okay, so a heat flash that's associated with dosing time. Can I come back to this question? Because I think I have a slide. Okay, cool. Any other questions?
Is there ever any, when people are getting cold, that part of it?
Thermal dysregulation. So being cold in Parkinson's, thermal dysregulation in Parkinson's, yes. Yes, that non-motor slide was very inadequate. Thank you guys for showing that to me.
Okay, that is the thing.
Yes, yes, yes,
We're not just sweating, you can also.
yes, yes.
Any problem taking vitamins with this medication?
No, and in fact, this is, okay, wow, you guys, this is like all of my clinic visits for an entire year. The question is vitamins and Parkinson's. Evidence-based guidance on vitamin B12, folate, and vitamin D, those three. Vitamin B12 and folate, what we used to do is check blood levels of those and then recommend or not recommend based on a blood level. Now the guidance has changed and we usually tell folks who are taking carbidopa, levodopa to go ahead and take vitamin B12 and folate as a standard thing. And it's important to talk to your doc about what you should be doing. If you're taking those supplements, I usually encourage people to bring their supplements to their doctor to make sure that they're doing this appropriately. Sometimes supplements have other vitamins in them that you shouldn't be taking a lot of. So it's not good just to take 7 multivitamins. No, okay? Vitamin D is associated with poorer cognitive performance if vitamin D is low in Parkinson's. So there's a good paper about cognitive impairment in Parkinson's that can be partially reversible if a low vitamin D level is normalized. Okay, so we like to check vitamin D levels, and we like that most people take vitamin B12 and folate. The B12 folate thing comes from data that shows some people
Shouldn't have no what it was.
pseudoephedrine.
What's the Is that like Benadryl or?
Not Benadryl, Sudafed, yeah, yeah.
So it's just, yeah. Okay, yes.
Did you guys hear that question? Yes. Okay, so the question that I just answered was, I wanted to take a cold medicine and I read that it's going to interact with my Parkinson's medicine. And I was answering saying that not all Parkinson's medicines interact with Sudafed. A small portion do. Check with your doctor. Okay, question.
Maybe I missed it. Does Parkinson's make the B12 drop?
No, Parkinson's doesn't make the B12 drop. Great question. What carbidopa-levodopa metabolism may do is create an inflammatory byproduct called homocysteine. And to counteract that inflammatory byproduct, we give B12 so it doesn't happen. That would have been an easier answer. Yes.
What's D3?
Yeah, you guys. So D3 is usually what we should take, and I don't recommend just taking something over the counter without checking blood work or talking with your primary care doctor. So that's a primary care doctor question, and usually you should get a D level checked.
How many milligrams is usually bad? 2,000, 5,000, 1,000?
I'm not going to answer that. Check. They feel great. Okay. 5 years later, Dr. Solis-Cohen, my tremor's worse. All right, we're going to give you some more medicine. We'll see what goes on. Now I have to replace this amount, right? Not this amount. 5 years later, I'm freezing. I can't walk. I got to replace a lot of dopamine. They're getting dyskinesias. They're getting lightheaded. They can't take that medicine anymore. It's not that my medicine doesn't work. It's that the disease has progressed, right? The dopamine deficit has gotten a lot bigger. And now my ability to replace it is limited by dyskinesias, side effects, hallucinations. And I can't just like give them all the dopamine in the world anymore because it's not tolerable. So, and not all their symptoms are going to respond to dopamine therapy either. So over time, it's not that it stopped working, because I've personally taken care of a person who's been on dopamine therapy for more than 35 years and it was still working, but the disease progresses. So
That's what I'm saying, it's ineffective after a certain time for a lot of people, but not everybody.
the medicine is still effective. The disease has progressed.
Right. So the
So you
medicine
need
doesn't
too
work
much of it.
anymore.
Correct.
Tolerable.
Correct. Well, they've done studies to say what happened was, for example, 20 years ago, if you read a textbook about Parkinson's, it would have been, don't treat with carbidopa-levodopa early on. Hold that medicine because it's only going to be useful for 5 years, right? Don't treat them. And now what they've done is they've done studies to compare people who were treated early on in their disease process versus they waited and they started carbidopa-levodopa later on. Guess what? They all had motor fluctuations. They had ons and offs, they had dyskinesias, all of them. And starting treatment late motor states that they have. And on the x-axis is the time of the day, okay? So let's say this person wakes up in the morning and they take their levodopa. And their dopamine levels start to rise and they start to fall. I don't want to fall. And then they take another dose and it happens, and then another dose. But look where they are. They're in this bar here, and that's defined as a good on state. All right. They remain well controlled, even though their dopamine levels may fluctuate, but they're actually pretty well controlled. They have no concept of what on off is. Because guess what? They're here, they're on the whole time. Their medicines pretty equal. After progression and a person develops motor fluctuations, one day, okay, same person years later, they take their dose in the morning when they're slow, stiff, and they're off, okay? Now their dose may be bigger, so their dopamine levels rise higher. They enjoy a little period in a good on state where their meds are working, but they shoot into having dyskinesias, which are bothersome. Then as the medicine comes down, they're in that good on state again, but whoops, now all their slowness comes back. Dose again, cycle repeats. Dose again, cycle may repeat. That's the motor fluctuation. Imagine how many different versions of this person there is throughout the day. They don't get good on time the whole day. They get a fair amount, you know, they're in there multiple times, but now they're like, when am I gonna go golfing, right? How am I gonna go to the grocery store? I gotta get like time my meds. Where am I gonna eat a hamburger? Because I don't want it to make me go into the off state. So this gets to be pretty all encompassing, right?
Time.
Yeah.
Stress. It starts to rack up, gets worse, but then as soon as I got a situation, so we just kind of calm down. It gets
Yeah. Tremor is very annoying because, yeah, and it's all kinds of tremor, not just Parkinson's tremor. So folks who have different types of tremor, tremor when a person is sort of like feeling in control of the situation, they're not super stressed, they're not fatigued, and everything's sort of like controllable, they can maintain it to some degree. But when you've reached a certain like adrenaline situation, all tremor does that, regardless of when your meds are. So tremor is a hard motor symptom to always follow, because you have to keep in mind that it's not all a medicine story. There's life, right? Yeah, that's going to tip a person into being in the off state in and of itself, how much stress they may have. So this is just super simplistic for educational purposes, but there's so much more that goes into a day. I think I want to answer more questions that you guys had. No?
Now, what did Catherine Hepburn have? Essential tremors?
What did she have? Did she have spasmodic dysphonia?
She was always.
Or did she have essential tremor? I don't remember.
I'm thinking essential.
I was probably like too busy learning.
And essential tremors are,
I can look it up for you. Okay, you look it up.
I think she was asking what an essential tremor is.
Oh, what's an essential tremor? Oh, an essential tremor is the opposite type of tremor as
Other non-important to them, exercise.
Yeah.
Any recommended kind of exercise or just movement?
movement. Whatever you like and you're gonna stick with. Yes.
I noticed when I work out, right after the workout, I have a lot more shakes and tremors than normal, like I don't have after the workout. It's pretty severe. Is that pretty common, or something to be concerned about?
I don't take myself to be like an exercise expert in Parkinson's, but I've heard that. And I wonder if you're adequately hydrated, nutrition beforehand, and also if the level of exertion is too much for that period of time. So if that's the case, like break your exercise up into smaller, less aggressive sessions.
Yeah, when I do just aerobics, it's not so bad.
Yeah. Yeah, so maybe separate it and see how it goes. Yeah.
Oh, I obviously was late, but did you go over any diet at all?
No. I say it like that because I feel like the nutritional guidance in the world of Parkinson's gives a lot of mixed messages. And it's not FDA regulated studies, because it's not medications, they're they sort of occur on a different level. I think the best data came out from the Journal of American Medical Association, probably 5 years ago, that said they actually looked at diet in folks who were prodromal PD, so people who had the prodromal symptoms, and watched who converted to Parkinson's earlier versus later. The people who converted later followed the Mediterranean diet. So it was sort of a takeaway, Mediterranean diet in Parkinson's, and prodromal probably does more. So I usually tell my folks, there's some data that's like, avoid dairy, avoid red meat, avoid processed things. And then I'm not really sure what to follow, even as a movement disorder doctor myself. So I'll usually say, refer to that study because it was in JAMA. And Mediterranean diet offers many health benefits. So that's my line. Yeah, are we having a nutritional talk?
We had a nutrition webinar today that will be posted on our website or probably by next week. And I would say that most nutrition webinars that we've had, it's the same thing. It's really follow the Mediterranean diet. And then there's another, it's good